My name is Wendy Ross. I'm the Assistant Director for the South Central Telehealth Resource Center, and I'm welcoming everyone to the National Telehealth Webinar Series. Today we're talking about changing healthcare delivery, the UMMC Center for Telehealth on the Rise. So first I want to tell you a little bit about the Telehealth Resource Centers. If you are new to these webinars, these are webinars that we offer on the third Thursday of each month at no charge. They're just here as educational to help everyone expand, adopt, and learn more about telehealth. The Telehealth Resource Centers, there are 14 across the country, and there are 2 national centers. The Center for Connected Health Policy, located out of California, and also TTAC is our Technology Assistance Center. And we also have 12 other regionally focused centers. For instance, ours is the South Central Telehealth Resource Center. They're the red states there in the center of Arkansas, Mississippi, and Tennessee. We would also like to let everybody know that in about a week, we are hosting the South Central Telehealth Forum in Nashville, Tennessee. Everyone's invited. We hope you'll take a chance to take a minute to look at our website, look at the agenda, and think about joining us there in Nashville. So as I said, our topic today is changing healthcare delivery, the UMMC Center for Telehealth on the Rise. And our speaker today is Mr. Michael Adcock. He's the administrator for the University of Mississippi Medical Center. Michael has a long history at UMMC. From starting as a staff nurse at UMMC, he's also earned his degrees there, and he is now, as I said, the administrator for the Center for Telehealth. He is also a fellow in the American College of Healthcare Executives, earning multiple recognition and awards, and he's also an honor member of the South Central Telehealth Resource Center Advisory Council, and we're so lucky to have him, and lucky to have him talking today about the Center for Telehealth. So with that, I am going to pass it over to Mr. Adcock. Well, I think I'm going to. I may need Becky to help me try this again.
Go ahead, and we lost your slides. Share your slides again, and then just.
Can you not see them now?
Yes.
Okay, you can see them. Okay.
Under options, and then give Michael. Actually, it's going to say Megan.
Right. Okay, there it is. It just wasn't popping up. There we go. How about that?
All right. Let's see if that worked.
All right, we can see him.
All right, I'm trying to see if we can get the slides to advance.
Not working for you?
Not so far. Hold on just a second. Let's see.
If that doesn't work, I can advance them for you.
Yeah, if you click on the main screen and then.
There you go.
There we go. Nothing like a little technical problems on a telehealth webinar. Well, thank you, Wendy and Becky. And my name again is Michael Adcock. I'm the administrator for the Center for Telehealth at the University of Mississippi Medical Center. And it's my pleasure to speak to you this afternoon about telehealth in general, and specifically about our Center for Telehealth and our journey and where we see telehealth going in the future. I'd like to thank Becky and Wendy and the South Central Telehealth Resource Center for allowing our center to speak to all of you today. So, learning objectives. By the end of this webinar, I hope to have conveyed the need for telehealth services in rural communities. I will discuss with you the cost-effective benefits of a comprehensive program which allows individuals to stay in their community and, when possible, their home. We'll also discuss remote patient monitoring and its feasibility in managing chronic diseases in patients' homes. So, Center for Telehealth. What is telehealth? I think this is, most of you don't need a definition of what telehealth is, but I will, basically to us, telehealth is a technology that allows providers to examine and treat patients remotely. So connecting patients and clinicians with providers at our specialists at our medical center at UMMC. Also allows us to connect providers to patients outside of our medical center to their own patients. So why is telehealth important? For those of you in rural communities, certainly all of us in the South Central Telehealth Resource Area, Mississippi is a very rural state. 53 of the 82 counties are more than 40 minutes from specialty care. This leads at best to delay in receiving specialty care, or worse than that, care never being received. We have a severe healthcare workforce shortage in Mississippi, and there is certainly a healthcare workforce shortage across the country. We do not have enough providers for our population. This has led us to use technology to optimize this healthcare workforce. Telehealth allows us to provide specialty care that is convenient to patients and supports primary care physicians across our state. That support is vital to these primary care physicians out in rural communities. It helps decrease the cost of care and improve patient outcomes. We're also able to support our rural providers by providing interactive distance education to improve quality of care throughout the state. A little bit about our telehealth journey. In the 1990s, we were doing what most everyone else is doing, which was diagnostic test interpretation, adult and pediatric cardiology and radiology. In 2003, we started our first live telemedicine program, which was TelEmergency. This connected rural emergency departments across our state with our level 1 trauma center. In 2000, and I'm getting a little feedback. Is anyone else getting feedback? Okay.
I'm muted, Wendy.
Okay. In 2008, we started providing behavioral health in addition to our TelEmergency program through telemedicine. Up until 2011, everyone who was working on telehealth at UMMC was doing so under the part of their job description, and we all have it, other duties as assigned. They were doing this in addition to their full-time jobs. They did this because they saw healthcare needs in Mississippi that they thought could be addressed through technology, and they were right. In 2011, our IT director, Greg Hall, became the very first full-time telehealth employee at the University of Mississippi Medical Center. Since then, we have approximately 50 employees right now who are full-time providing telehealth as their full-time jobs here at the Center for Telehealth. In 2013, this work was turned into the Center for Telehealth at UMMC officially. So as an academic medical center, we have certain designations and hours as the Center for Telehealth. We have a 24/7 telehealth call center, and we'll go into the services that we provide in just a moment. There we go. So telehealth, we see telehealth as the umbrella term to multiple modalities. Telemedicine is the live audio video interaction. These are all the services that we provide. Telemedicine is that live audio video interaction, both scheduled and unscheduled. Could be consult, primary care, employee and student health, prison health, ancillary health, and wellness services. Remote patient monitoring, that is our chronic disease management in patients' homes. Hospitals are extremely interested in this because most all hospitals that I've ever worked with have at-risk populations and use this as a cost avoidance and cost reduction mechanism. We can provide this service through connection with clinics. ACOs are very interested in this, as are insurances and private practices. We also can provide post-acute monitoring through remote patient monitoring. Store and forward and diagnostic test interpretation. For a while, for us, that was both adult and pediatric cardiology, some radiology and neurology. Now we have added audiology, dermatology, pathology, and ophthalmology to those as well. So that is a new service, and dermatology specifically has allowed us to decrease the time to appointment dramatically. So we currently cover approximately 35 types of telehealth specialties between adult and pediatric services. These range from emergency medicine to urgent care, mental health. We monitor 96 beds in our EICU program. We have remote patient monitoring and also provide sideline concussion evaluations, just to name a few of the 35 specialties that we offer. These specialties were chosen, just like most of our programs were, because of needs in the communities and that are generally where the specialties are not available outside of the metro area. So our telehealth program, by the numbers, we've helped over 800,000 patients since 2003. We currently have over 200 UMMC available specialists who are available to provide specialty services through telehealth. Like I said, we have about 35, a little more than 35 specialty services, and we grow those every day. and we have over 200 sites of service across our state. To be exact, we have 218 currently, and we will be at 220 in the next couple of weeks. So on the left of your screen here are the 8 different types of locations in which we provide telehealth services. So you have your standard community hospitals and clinics model, mental health clinics, federally qualified health centers, schools and colleges, mobile health vans, corporations. We have a corporate health program. Prisons, we have prison care. We are providing infectious disease services in prisons. Most everyone is very happy about us providing those services. The hospitals, the Department of Corrections, the prison guards. The only people that aren't really are the prisoners, because they enjoy being able to get out of their prison cell to come to the hospital every once in a while. And we're also, our most recent foray is into the patient's homes through remote patient monitoring. On the right side of the screen are the counties in which we provide sites of service. So if you look, the blue-green shaded areas are where we have a site of service, at least one site of service in a county. So 68 to 82 counties in Mississippi, we have sites of service of one type or another. Most of those counties, we have multiple sites of service. So like I said, TelEmergency was our very first live telemedicine program, and this was connecting rural ERs throughout our state to our level 1 trauma center. This need came about because we have like a lot of other rural centers do. Other rural states do. We have hospitals, critical access hospitals, and other rural hospitals across the state who are struggling financially, struggling to find the appropriate staffing levels for their emergency department. So we decided that we would try to address these issues through technology. This program allowed us to staff these emergency rooms. The local ER staffed their emergency room with nurse practitioners who they employed, but we trained through our training program to make sure that they were competent both clinically and administratively and understood the technology of actually providing a telehealth visit. So we started with 6 ERs back in 2003, and we're now up to 15 emergency departments in rural hospitals that are connecting through live audio video with our level 1 trauma center. We use real-time video and audio connections. Some of the benefits to the hospitals out in the communities, they've seen a 25% reduction in rural emergency staffing costs. And most of this was due to the fact that a lot of them were staffing with locum tenens, which is extraordinarily expensive because they could not get the physicians that they needed in their ER. We also saw a 20% reduction in unnecessary transfers. So these patients were being shipped from these local ERs where they didn't have the medical training or the staffing that they needed to our level 1 trauma center, which overburdened our ER, but also took patients out of their community that could be provided care for in their communities. What we've seen with this is being able to produce patient outcomes that are on par with those that are delivered here at the academic medical center. So if you go into one of our TelEmergency sites out in a rural community having a heart attack, we can deliver the same level of care there that we can here at the medical center. So some outcomes evaluation. One thing that we found is extremely important in all of our programs is to measure our outcomes. So like I said, we've got 15 rural Mississippi hospitals right now. We've treated over 500,000 patients through TelEmergency alone. We have a multidisciplinary team, as I mentioned. A nurse practitioner could potentially be a family medicine physician or some other type of physician at the away site. And on our side is a board-certified emergency medicine physician faculty member at our level 1 trauma center. Again, we decreased the expense in staffing and increased admissions locally by 20%. Obviously, this is something that is very interesting and very needed. The local hospital administrators are very happy with being able to increase their admissions locally instead of those patients having to be transferred somewhere else. Okay, more outcomes evaluation, satisfaction surveys. Our first quarter of 2014, we had 100% physician satisfaction. The physicians in the community and here on site are very happy with TelEmergency. They get a sense of security by us helping them with cases that they were trained for, but they may not have seen those cases in a couple of years. So being a very busy level 1 trauma center in an urban area in Mississippi, being able to see those cases every day, our physicians gain expertise and common knowledge of things that come in that may not be seen in some of these rural communities. So the physicians and the nurse practitioners out in these communities are extremely satisfied with our program being able to provide that support and the care that the patients need in these communities. Total patients seen up to this point in a couple of sites were 884 patients. Admissions were 208. Admissions to the facility increased by 101 patients in the first quarter of the program. So obviously that center was extremely happy with the way that the service helped them keep their admissions locally and provide a level of care that they needed. So our telehealth strategy is like a lot of other people's telehealth strategy. We believe we are trying to improve access to quality care across our state. We're trying to improve the health and wellness of our state and any population that we're covering. We believe in education, training, and collaboration. Because our program is tied to the Academic Medical Center here in Mississippi, education is one of our mission. We are training health professionals every day, and we are now adding telehealth to the training curriculums for multiple medical school, school of pharmacy, school of nursing. They all have telehealth in there or are working on telehealth being as a part of their curriculum so that we can train the providers of the future to understand what telehealth is, what telehealth isn't, and how to perform a telehealth visit. Collaboration amongst not just us, but also collaboration amongst the healthcare providers and healthcare entities in Mississippi is extremely important to us. Gone are the days of trying to compete with everyone and trying to come in and take over the whole world, or at least take over Mississippi. We have to work together, and we need these community hospitals to stay open, and we need to make sure that the providers are working together for workforce resource optimization. Like I said before, we do not have enough physicians in the state of Mississippi. I'm quite sure that in most of your states, you don't have enough physicians either. So we're trying to optimize that workforce as best as possible, and technology allows us a way to do that. So strategy, all of our programs at the Center for Telehealth were created to meet consumer need and provide them access to quality of care. So our programs are consumer focused and provide a solution or competitive edge. We believe that quality and access must go hand in hand. Access to lower quality care is not something that we can support or in any way allow to happen in our telehealth programs. You have to have quality enhancement in order to decrease our risk. Resource optimization is important across our state and across the nation. There may be people on this call who are blessed with pediatric cardiologists or pediatric neurosurgeons. We're not. So we need to make sure that we're using those resources as efficiently as possible. Telehealth also allows us to work with providers and staff to coordinate care across our patient population. As our state's only academic medical center, we have a responsibility to provide services across our state. And the only way we can provide those services is to collaborate and communicate and coordinate with all of the providers throughout our state. That is something that is extremely important to the success of our program. We are not out there to compete with anyone. We are out there to serve a population through population health. So we want to provide a turnkey solution for our communities. Turnkey solution does not mean that we are a one-size-fits-all and here's our program, and if you don't like it, too bad. Our program is very much adaptable. We go in and we ask these community providers, whether they be a hospital and clinic, a FQHC, a private practice, what are your needs? What can we do to help you? It may be that they need behavioral health. Almost everyone needs behavioral health services in their communities. If that's the need, that's what we go in and do. And we're trying to build capacity in these communities and strengthen the relationships between us and the providers in the communities, and also between us and the community, so that they know that we are here to support them and help their community be financially stable. Without these community hospitals, all the patients have to go to a regional referral center. That is not the goal of our program. Our program is there to support community-based care. We're trying to support population health through community-based care. So delivery of care, this is a very simplistic side, but I'm going to have it up there for just a moment anyway. Obviously, the specialist in most cases are on our side of care. So we have the specialist at the University of Mississippi Medical Center. The patient is on the other side at the rural hospital or clinic or other site that is designated for care. So how do we set up programs? A big piece of our program is clinical quality. We require that all of our programs maintain the same standard of care as you would have in-person care. If our technology cannot replicate the exam you would do in person, then the visit is not appropriate for telehealth, and we will not cut corners. So if there is a service that we need to provide that we cannot provide through telehealth, we will try to help whatever system it is or whatever hospital, clinic, private practice physician. We will try to help them get the resources they need in person or get them referred to the right place, because we do not believe in cutting corners, and we must maintain the same clinical quality. Our clinical outcomes, we're studying our clinical outcomes constantly to make sure that they are on par with in-person outcomes. Supplying access to high quality care is the important part of our program. Just supplying access to care that may not be as good as what you can get in person is not what we're about. So obviously we're all focused on population health management. So when we're talking about future areas of focus, this is not just a future area of focus. It is a current area of focus. I bet if I asked everyone on the call or everyone on the webinar what the definition of population health is, we'd all have something that's somewhat similar but a lot different in many ways. So we are focused on population health management in our state. We actually have a school for population health management, which was approved about 2 months ago, and we will use telehealth as a tool to help with population health management. We can manage the population using the technology tools and the clinical programs that we have built through the Center for Telehealth. Another area of focus is patient engagement. Engaging patients in their care is extraordinarily important in changing behaviors. If the patients aren't engaged in what we're doing things to them just like we've been doing throughout the history of healthcare. We have to change the delivery model, and we have to change our patients' engagement in their care and empower them to take care of themselves. Being able to access and share data to ensure coordination of care is another item that's a key focus for us. I know that this is a national issue, if not international issue. People receive care where they are. In order for us to make sure that that care is complete and coordinated, we have to make sure that we're able to share and access that data across systems. If not, there is no success to the program. We also have to track outcomes and analyze them to determine the success of our program. Just providing telehealth without knowing whether or not we're doing it in a manner that is high quality or improved efficiency or low cost, it's not worth us spending time creating a program if we're not going to analyze the outcomes. Provider adoption. I know any of you that are just getting started in telehealth or have been doing telehealth as long as we have for 13 years, convincing physicians and providers that telehealth is a huge tool and a new way to deliver healthcare is a constant, I wouldn't say struggle, but it's a constant area of focus. So we have lots of opportunities to improve provider adoption across not just our system. I would say that internally at the Center for Telehealth and at UMMC, we have a great adoption of telehealth, making sure that providers in the community understand the benefits of telehealth and how we can help them. And most importantly, and I hope that everybody can agree with this, that we're not there to steal their patients and take them away through telehealth and decrease their revenue. That's not the goal of this. The goal is to make sure that these patients can receive high quality care. So we're going to go into remote patient monitoring and our Mississippi Diabetes Telehealth Network. The reason that we started this telehealth network, and this was a study started a couple of years ago, was because of some of the statistics that are on the page, on this slide that you see in front of you. In Mississippi, we are blessed to be number one at a whole lot of things. Unfortunately, those things that we're number one at are not always positive. So we have the highest percentage of adults diagnosed with diabetes. In 2011, 7 of the leading causes of death in Mississippi were chronic disease related. Diabetic medical expenses in 2012 in Mississippi totaled $2.74 billion. That's Mississippi alone for diabetic expenses. That's not sustainable. Our population we're not that populated a state. We are very rural, and $2.74 billion in 2012. That continues to grow, and that's just not sustainable. We had to do something to try to reach patients and be more effective in our diabetes care. So we started the Mississippi Diabetes Telehealth Network with the purpose of improving clinical outcomes and care coordination for chronic disease management, increasing access to quality care, and bringing healthcare resources into the patient's home. At this point, this was the first foray into remote patient monitoring into the patient's homes for the University of Mississippi Medical Center. This was a partnership between multiple entities. The Mississippi Office of the Governor of Mississippi, Mississippi Division of Medicaid, all of our schools here on campus. So the School of Pharmacy, Nursing, the School of Medicine, C-Spire is a regional cell phone and wireless provider. It's the largest privately owned cell phone and wireless provider in the country. They partnered with us on this, as did Care Innovations and GE. So we had both a public and private partnership with North Sunflower Medical Center. We chose Sunflower County as an area to focus because, one, it's in the Mississippi Delta, which is ground zero for diabetes and chronic diseases across our state. It's a very rural area. It's underserved by all means, and there are lots and lots of health disparities in the Mississippi Delta. So we chose there, figuring that, one, we could see if chronic disease management through remote patient monitoring worked, and if we could make it work in the Mississippi Delta, we could make it work anywhere. So we chose North Sunflower, and they've been a great partner to us. So our remote patient monitoring program through this study, the study is where it started. We were looking for 200 uncontrolled diabetics in the Sunflower County area. We screened at least that many and ended up having well over 150 enrolled in the program. These patients that were enrolled received some technology at home, which consisted of a tablet and some peripheral devices, a glucometer and a scale to monitor their biometrics. And remote patient monitoring, again, is the delivery of health services at home using telecommunications. So these patients were required to conduct daily health sessions. So they went on their tablet and they answered questions, health questions. They read educational materials every day, and they're required to do this every day. They received personalized interventions, targeted education. All of the education that are on these tablets is evidence-based. It is on a 4th to 6th grade reading level so that people can understand it. It also has an audio function so that those patients that cannot read are still able to participate in the program. They receive a health coaching as a part of the program. And the goal to all of this is to educate these patients on their chronic diseases. So education, engage them in their care. A lot of these patients, at least in this study, had never touched technology. Most of them knew very little about their disease, and that was no fault of the providers of care in their areas. It's the fact that there is a limited amount of time to spend with these patients to educate them on their disease properly. So we're trying to educate, engage, and then empower these patients. We want these patients to understand their disease process. We want them to understand what it takes to improve their health, and we want to empower them to change their behavior so that they can take control of their disease instead of their disease taking control of them. So this study is still ongoing. It will finish in September. So we will have the last patient. It's a rolling 12-month study. The last patient will come off in September. We will have full results of the study then. But right now, and we had preliminary results on the first 100 patients, first 6 months of this study, and the hemoglobin A1C decrease was 1.7%. That was favorable to our goal of 1%, so we saw a pretty dramatic reduction in hemoglobin A1C. Medication compliance was 96% among the study participants, those first 100 patients. Nationally, that's about 60%, so we were able to really, really help these patients comply with their medications. Health session compliance, like I said, they have daily health sessions they have to complete. They were 83% compliant with those health sessions. Early disease detection is something that telehealth can really help with, and we found 9 cases of diabetic retinopathy in these first 100 patients, first 6 months. And 9 patients doesn't sound like that much, except these were 9 patients who would have likely gone blind if not for the early disease detection. So what these patients knew of diabetes was that their family members had it. Their grandmother had it. Their mother had it. They both lost limbs. They lost eyesight, and then they died. And most of these patients thought that that was the path that they were going to have to go down. So we were able to help them with some of those things. Was not a weight loss program, but they lost 71 pounds in the first 6 months. It saved right at 9,500 miles traveled through our telehealth program. The one that most hospitals and health systems and payers are interested in is the last line on there, the last bolded line: no hospitalizations or ER visits for diabetes in the first 6 months, first 100 patients. So none of these patients who were frequent flyers to the ER went to the ER in the first 6 months. That's a pretty dramatic result. So what did the patients think about this? Like I said, a lot of these patients had never touched technology. These are just some of the comments, and I won't read all of them to you, but the patient on the left with the pink shirt on is actually one of our spokespersons for this program, and she was not familiar with technology at all, and actually is now riding her bicycle to the library to blog about diabetes care. So this program works. I've learned more in the program than I did when I was in the hospital. Some of these patients had never thought to look in their shoes. Well, that's very important with diabetic care, obviously. And the one that I like the most is, and this is me speaking as a nurse, I've learned more in the few months of being in this program than I have in 17 years of having diabetes. I can tell you that when I discharged patients from the hospital, I thought I did a fabulous job educating them about their disease. And I think I did in the time that we had to educate them. Unfortunately, patients don't learn best when they're in an environment that is stressful. They're worried about their new disease or a chronic disease. They're worried about how they're going to take care of their patients at home, their family at home. They're worried about how they're going to pay their bills. So we go in and educate them with a 3-inch packet of material, and they nod their head and they leave and they end up being readmitted, or they're not able to take care of themselves the way they need to and just continue to worsen. So being able to provide education in their homes where they're comfortable in small bites pieces, while at the same time providing real-time interventions. So when these patients check their blood sugar and it's been running relatively normal or moving in the right direction, and all of a sudden they hit a huge spike, we know about it. Our nurses are here at the center watching these patients constantly as far as their biometrics and their medication compliance and the answers to their questions. So we know when things have gone awry, and we contact them immediately. That they know that. And so one of the stories that we always tell with our program is that one of the hospital administrators' dad was on the program, and they always eat Sunday dinner together. And so at Sunday dinner, right after Sunday dinner, they always have pecan pie. Well, about the third week of the father being in the program, it got time for pecan pie, and he said, "No, thank you, I don't want any." And the son thought, "Well, why, Dad? What's wrong?" He said, "Well, I know that if I have this pie, Nurse Cindy's going to call me tomorrow." That's behavior modification. That is real-time intervention. And the only way to really get things to change is for people to know that if they change these behaviors, they start to feel better and things improve. So this is the slide that was put together between Care Innovations, us, and the Mississippi Division of Medicaid. It's a very busy slide. It actually looks really good on a poster board. The focus is going to be on the right-hand side on projected savings. So first 6 months, first 100 patients, we calculated Medicaid calculated a savings of $339,000. 6 months, 100 patients. They calculated that if 20% of the diabetics in Mississippi on Medicaid were on this program, that we would see $189 million a year reduction in diabetes-related care in our state. That's just for 20% of the diabetics on Medicaid. Those are also only hospital costs. So the cost reduction capabilities are pretty dramatic. So being able to impact chronic diseases across our state through remote patient monitoring was seen as a very successful way to manage chronic diseases. In Mississippi, and I'll talk policy for just a second, in Mississippi, we are blessed to have a couple of years worth of great policies that were passed through our legislature. 2013, we had payment parity. So we're one of the states that has payment parity for any telemedicine visit. We also in 2014 had Senate Bill 2646, which allowed for store and forward technology to be seen as an approved method of telemedicine, telehealth. We also, remote patient monitoring was required to be funded, required to be paid by all in-state payers. So Medicaid and all the private insurers in Mississippi have to pay for remote patient monitoring if criteria is met with chronic diseases and number of admissions or readmissions over a certain period of time. So we are lucky in that fact that we were able to, through a lot of hard work and a lot of support of both our state and our congressional delegation in D.C., certainly pushed on that as well. From D.C., they pushed on their colleagues in Mississippi, but we were able to get those both passed unanimously. And I think that speaks to the leadership and the courage of our legislators in Mississippi to promote telehealth in a way that can both improve access to quality care and decrease the cost of care. So where are we going with RPM? We're going to monitor patients across multiple chronic diseases now. So we started with diabetes in the pilot study, as soon as we got those preliminary results back, we started making plans and implementing our plans to provide remote patient monitoring across multiple disease conditions. So chronic CHF, COPD, asthma, adult and pediatric asthma, adult and pediatric diabetes, hypertension. There are multiple diseases where we have clinical programs built and we're enrolling patients in remote patient monitoring. We see this as a significant cost savings. Even for those conditions that aren't currently being reimbursed, hospitals and payers are contacting us to create programs to help them manage certain populations that can be helped through at-home monitoring and chronic disease management in the home. Extending outside of Mississippi's borders, our program has always been a statewide program, or been meant to be a statewide program. Like I said, we're in 68 of 82 counties. We're working with the health department to get into all 82 counties, but now we're looking outside of the borders for remote patient monitoring to see if we can help other states and other hospitals and other providers take care of chronic diseases in patients' homes. And we'll continue to continue innovative approaches to bringing healthcare resources into the patient's homes. Right now, that's a tablet and Bluetooth peripherals. That could very well be on smartphones, in-house devices. There's lots of ways for us to connect with patients where they are. And that's the goal of our program, is to connect with patients where they are. So that's where we're going with our remote patient monitoring program. So this slide is titled "Changing the Game." Our team is dedicated to helping healthcare organizations deliver better care and access to more patients at a lower cost. Obviously, we're trying to provide resources and clinical expertise addressing today's quality, cost, and access challenges. So the triple aim is in full effect, obviously. We talked a little bit about it. We do 100,000 telehealth visits a year. We focus on our patients' experience. We have 218 sites of service, 35 plus medical specialties. We also do our very best to ensure the right technology. We don't mandate that certain equipment be in every center, every site across our network. So if we're delivering audiology, obviously we need specialized equipment. But if we're delivering behavioral health, we try to match the technology to the service that we're providing so that we're as efficient as possible and that we're as cost effective as possible. We do that through partnerships with multiple people, and I've talked about some of them: Care Innovations, AT&T, GE, C-Spire. We're looking for standardization across our platforms, but also collaboration and adaptability. So we have to make sure that our program can be fitted to whatever environment we're going into. Not everybody has the same wireless access. Not everyone has the same capacity and bandwidth in their internet connections, and not everybody has the same space availabilities that we might need for certain technology. While we're trying to standardize our processes, we're trying to be as adaptable as possible and as flexible as possible in the delivery of that care in those centers. We're attached to the state's only academic medical center, and we have the full support of all the leadership at our academic medical center. It is actually in our strategic plan for the medical center. Telehealth plays actually speaks to several objectives in our strategic plan across the organization. We have a great relationship with our congressional delegation in Washington, D.C. Also have great relationships with the FCC and all the other regulators and key players in Washington. And what we're trying to do with that is partner and work with people to help drive a standard across the country, because one of the things that really concerns us at the Center for Telehealth is making sure that we're all delivering high quality care across the country. I think we all have to work together to do that. I think we need to all, not just academic medical centers, all like-minded centers who want to provide access to high quality care. We owe it to each other to work together to try to make sure that those standards are set nationally so that we can provide high quality care. Because for everybody that gets involved that is not providing the quality of care that needs to be provided, it tarnishes telehealth as a whole. Our governor is a huge supporter of telehealth. He speaks about our telehealth program and about telehealth in Mississippi everywhere he goes. He has been a great asset to us and is certainly a good friend to our program and making sure that we have what we need. Driving a cultural change via RPM, creating a culture of accountability and operational excellence, creating standardization, a standardized philosophy for services and equipment, and collaborations with key partners. Our program was built through partnerships. It is not us trying to be the end-all be-all for everybody across our state or across the nation. It is us working with people who either need our help or who can help us to make sure that we're providing access to high-quality care. Some of our big swing strategies we've talked about is RPM, collaborations, healthcare access for all, Rural expansion, we're doing projects. Like I said, Mississippi is a very rural state, and we have hospitals closing in our state. We're trying to work with our local communities to provide access to care. May not be reopening a hospital, may not be us taking over a hospital, but we want to provide the right level of care for communities across our state. And branding and expanding UMMC's name nationally. We have a program that we're very proud of. We have a program that is working to meet the needs here in the state of Mississippi. There are still lots of needs left to meet. We will continue to work on those every day. Every day that I think we've made progress, and we find 5 more things that we could work on to really help our people in Mississippi and people across the country. So we will continue to work through those and try to improve the level of health, not only in our state, but in any other states that want or need our help. So that was a very high-level overview with some details on our program. I again would like to thank the South Central Telehealth Resource Center for allowing us to do this and be a part of the National Telehealth webinar series. We are happy to be here. We are happy to answer any questions. I think we're going to go into questions in just a second. I'm happy to answer any questions that I can. If I do not know the answer, our team is very broad and very deep, and we have experts in every area. If I do not know the answer, I will get you the answer back. But I'd like to thank everyone for participating in this webinar and for putting up with my southern drawl and very fast speech. And I'm opening up to questions.
All right. Thank you so much, Michael. We do have quite a few questions. Wendy, do you want to run through the questions, or do you want me to kind of moderate them?
Well, let me see if I can do this. I appreciate everyone's patience as I'm having these technical difficulties here. Okay, let's start here. Let me see. Okay. So one question from Anthony is, what is the source of the data about the percentage of counties more than 40 minutes drive from specialty care?
What is the source of the data? I mean, I'm not sure exactly where that data came from, but it's pretty simple to get as far as the list of providers in our state. The majority of the specialty care that we're talking about is here in Jackson or in some of the other areas, Hattiesburg and the Gulf Coast and different areas. So that is data that is at the health department. Also, I'll get the exact area where that data was created.
Great, thank you. Buck asks, how would telehealth services that require a specially trained clinician for the duration of a lengthy procedure, such as that found in a sexual assault examination, save costs to providers?
Save costs to providers? I don't know that it would save costs to providers, but what we look at in those programs is, at least in Mississippi, we don't have unlimited supplies of providers who are able to deliver that service. And I can tell you that's a service that we just turned on not too long ago. That those providers are traveling all over the state trying to meet the needs of all these children that need their help. And them driving for 2 or 3 hours to go see patients in different areas takes away 2 or 3 hours of time that they could be seeing patients. So it's more of an increase in our optimization of resource utilization than it is cost savings for providers. So allowing these providers to use their time efficiently and see patients remotely, they can see a lot more patients than they can driving in a car.
Right. Of course, there's also, the gas savings and like you say, the time savings and all that. Great. Could you provide any examples of services where telehealth could not replicate the requirements for in-person care?
Well, I mean, there's certainly surgical things, and the fact that we cannot palpate some of the services that require palpation, we can't provide those services. I haven't had any request that couldn't be, since I've been here, I haven't had any requests that couldn't be delivered through telehealth, other than some of the shortfalls that we've had in provider availability. So we get requests for hospitalist service all the time. I don't have hospitalists at the medical center or providers that can provide that service to rural hospitals. So there's some areas where we don't have the providers needed to provide those care services. But there are certainly areas that require in-person connections that can't be met. Some of the immediate follow-ups for certain procedures require that lab work be done or things that be done as a part of the follow-up visit. But the majority of things that are being requested have been able to be done.
Great, thank you. Okay. who pays your doctors for the telemedicine consults?
Like I mentioned earlier, we have payment parity here in Mississippi. So the consults that they're doing are reimbursed through insurance companies or through the same means that they are in person. So we actually, through the medical center, collect that money, and they get that just like they would professional billing for any other consult. Okay,
thank you. A question from John: what was your demographics mix on private payer, Medicare, Medicaid patients who enrolled in this Mississippi Diabetes Telemedicine Network program?
Unfortunately, because it's still an ongoing study, there's only certain pieces that they would let us release. I can tell you that the Medicaid was probably one of the highest pieces of the demographics, but I cannot give you specifics at this point until the study is closed and they allow us to release more of that information. Those are the pieces that they were willing, through the IRB, willing to let us release at the time. So I can't release anything else at this point. But the Mississippi Delta, if you were to do a quick search of patients in Sunflower County and in the Mississippi Delta, the majority of them are Medicaid and self-pay.
Great. What type of remote patient monitoring programs are you developing for asthma?
It's an evidence-based asthma protocol, so that we provide education, measuring peak flows and spirometry, looking at O2 sats. There's lots of different measurements that we take in education and interventions involving pharmacists, nurses, and physicians as needed. But it requires a Bluetooth spirometer and peak flow meter that's been developed but is being integrated into our program right now. So that program is not live yet, but it will be live soon. And the reason that we're doing that, there are certainly peak flow meters and spirometers available right now. But one thing that we found with our remote patient monitoring program is we're requiring that the data be connected through Bluetooth, or the devices be connected through Bluetooth, for multiple reasons. One, manual entry of biometrics has not proven successful. People are not always 100% truthful when they're entering their biometrics if they know someone's going to call them on it. Similar to the fact that I'm not 100% truthful in my diet log when I think my wife might be looking at it. So we make sure that those are Bluetooth. And when we started the study in the Delta, we used tethered glucometers, and that causes issues for people who are not technologically savvy. They can most all figure out how to plug in the power cord, but even when you add one tethered device to it, it makes things complicated. So we look for Bluetooth to avoid manual entry and to make sure that we are making this as patient-friendly as possible.
Great.
And if somebody's looking for more discussion around any of the clinical programs, we have a full staff here. We've got a clinical director of nursing who'll be happy to speak to anybody. So just reach out to us afterwards, and we'll be happy to talk through any of the specifics of our programs. Okay,
great. We have a couple more questions for you. Actually, we have a lot of questions. We have a couple more minutes. So one question is, are you seeing opportunities related to teledentistry?
There are lots of requests for teledentistry, and we're in communication with our School of Dentistry to see how best to meet those. There are certainly dental needs across our state. So we're investigating those now and looking at what's out there to help meet some of those needs, and what our provider mix would look like, and the engagement of our School of Dentistry. It's one of the benefits of being connected to an academic medical center is that we do have the school that's there looking for ways to reach out across our state. So we are looking at that right now. We don't have any live teledental, we'll call it teledental. We don't have any live teledentistry services at this point.
Great. Regarding the remote patient monitoring platform, did you develop that in-house, or was that pre-existing?
The technology itself is actually through Care Innovations, which is an Intel company. They were the partners with us when we worked in the Mississippi Delta. After that study, after we got the preliminary results back from that study in the Mississippi Delta, we decided to do a request for proposal to find the very best technology partner possible. And we surveyed multiple companies and had lots of great responses to our RFP. Care Innovations was chosen as the selected vendor for that RFP, and we've signed a multi-year $41 million contract with them to be the technology provider. And they continue to work with us to develop new services and new clinical programs.
Great.
But I would like to say that the clinical content and the clinical programs were all built in-house. I mean, those we use some of their videos but all the clinical content was built by our staff here in the Center for Telehealth, working with our academic center.
Okay. Have you come across any issues with the home patient monitoring and connectivity in the patient's home? And if so, how did you address those issues?
So all of our RPM kits come with cellular connectivity. It's actually a part of the package that we provide. So they come with cellular. The cellular is enabled on these tablets. I'd love to say that there's been absolutely no issues with connectivity. There are always some issues because we're working with a provider in our state for cellular connectivity. We're actually able to work with them and work inside their database to find out based on address, what type of cellular signal is available out there. If it's not available through our local provider, we access other providers. If there's no cellular connectivity, we look to Wi-Fi or some other way. I will say out of the couple hundred patients that we've enrolled in the program, we've had a couple, maybe two, that we've completely not been able to provide services for. And in those cases, we obviously don't send technology to their home and charge them for something where it's not connected, because that's not part of the program. We look to refer them to whether it be home health or some other type of service so that they can get their care. In areas where there's any huge gaps in service, which there's not that many in Mississippi anymore because of C-Spire and some of the other providers, they actually work with us to try to improve the cellular signal and the cellular availability in those areas.
Great. One or two more questions here. What do you feel has been the most prominent barrier when launching a telehealth program?
I would say that the most prominent barrier to telehealth in general, I won't just say in implementing a program, but to telehealth in general, is a lack of information and misinformation about what telehealth is, what telehealth isn't, and how it can be used. That's both providers, consumers, regulators, systems. Everyone seems to have a different idea of what telehealth is. Some people have no idea what telehealth is. And we've had a program for 13 years, and I'll say that there's still a lack of knowledge of our program, even in our own city. And that we just have to continue to spread the word. Provider adoption, I would say, is one of the bigger issues. And going out in these rural communities, when you're talking directly with providers, having them, again, to understand that we are not there to compete with them. We are there to help augment their services or provide access to specialists that they can't provide in their clinic through regular means. It's just trying to convince people that the old model of competition is no longer what we're looking to do. We're looking to cooperate and try to help people stay in their communities.
Very good. Thank you so much. I'm sorry, I just may have just missed my question here. It looks like we're about out of time, and I know there are a lot of other questions. So I'm trying to figure out the best way to do that. I may send those questions to you on email. We get some answers, and then we do a follow-up blog post or something.
Sure.
One of the questions was about, would this recording be available? And yes, it absolutely will be available. We'll get that recording, and we'll get it posted on learntelehealth.org and also, I believe, on the National Telehealth Webinar site. And we will send out information about how you can access that link just as soon as possible. And again, we'll try to get all those other remaining questions answered via a follow-up blog in that way. So first I want to say thank you, Michael. This has been extremely informative. It was wonderful to hear about the UMMC Center for Telehealth. I also have a lot of questions, so I may send those to you as well. So let me go ahead and tell everybody and invite everybody to our next webinar, which again, it's the third Thursday of every month, but our next one will be on August 11th, and it's featuring Dr. Ronald Weinstein talking about the update on telepathology and digital laboratory networks. Your opinion about the webinar is very important, so if you wouldn't mind, take a moment to complete the survey shown here at this link. And anything we can do to make the information we put in future webinars would be great to hear from you on, and of course how we can do better. So again, thanks everybody. I'm glad you joined us, and I hope to see you again very soon.